Hello everyone. In today's video, we will be exploring the fascinating world of ECG changes, focusing on the impact of medications, electrolyte imbalances, and metabolic factors. Stay tuned to deepen your understanding of these critical aspects of cardiac health. The electrocardiogram is significantly influenced by various factors, such as drug effects, electrolyte imbalances, and other metabolic conditions. The ECG can serve as a crucial initial indicator of life-threatening abnormalities, like hyperkalemia or tricyclic antidepressant toxicity. This class introduces these topics and briefly reviews nonspecific and specific STT changes. Abnormal serum concentrations of potassium and calcium can significantly impact the ECG. Hyperkalemia can be lethal due to its cardiac toxicity. Progressive hyperkalemia produces a unique sequence of ECG changes affecting depolarization, which are the QRS complex, and repolarization, with widening QRS complexes. As serum potassium concentration rises further, QRS complexes continue to widen, eventually leading to a large undulating or sine wave pattern, asystole, and cardiac arrest. Recognizing early signs of T-wave peaking is crucial for potentially life-saving interventions. Hyperkalemia is commonly seen in kidney failure, where potassium excretion is reduced. Take a look at this ECG displayed on the screen. We can clearly observe a significant widening of the PR interval accompanied by a sinus rhythm. Additionally, there is an extremely widened QRS complex that does not correspond to any specific conduction disturbance, such as left or right bundle branch block. This widened QRS complex is also associated with a sharply peaked T wave. These findings suggest a potential case of severe hyperkalemia. Hypokalemia results in distinctive STT complex changes, typically causing ST depressions with prominent U waves and prolonged repolarization. With hypokalemia, U waves often become enlarged and may exceed T wave height. Accurate QT interval measurement can be challenging due to merging T and U waves. Take a look at this ECG. It is a 24-hour monitoring tracing from a 46-year-old female patient with tubular renal disease, leading to severe and refractory hypokalemia. Notice how the QTc interval is extremely prolonged, making it easier for ventricular arrhythmias to occur and posing a high risk of torsades de pointes. If we were not familiar with the clinical case, we might consider a diagnosis of congenital long QT syndrome. Ventricular repolarization is shortened by hypercalcemia and lengthened by hypocalcemia. In hypercalcemia, QT interval shortening results from a shortened ST segment, with the T wave appearing to take off immediately after the QRS complex. Severe hypercalcemia may lead to coma and death. Hypocalcemia lengthens the QT interval, usually by extending the ST segment. However, ECG changes may not be diagnostic in patients with clinically significant hypocalcemia or hypercalcemia. Hypomagnesemia and hypermagnesemia are critical, as they may be overlooked and play a role in ventricular arrhythmias and other metabolic disturbances. Neither is associated with specific ECG alterations. Hypomagnesemia, typically caused by gastrointestinal or renal losses, may contribute to hypokalemia. Hypomagnesemia has been implicated in ventricular arrhythmogenesis with acute myocardial infarction and torsades de pointes. Intravenous magnesium administration is recommended in cases of torsades. Hypomagnesemia may also potentiate digitalis toxicity and foster hypocalcemia by inhibiting parathyroid hormone release. Hypermagnesemia, typically due to renal failure or excessive intake, does not produce distinct ECG abnormalities when mildly or moderately elevated. Pronounced elevations may lead to prolonged PR or QRS intervals, with extreme elevations potentially contributing to cardiac arrest. Hypotension due to vasodilation and mental status changes may occur with progressive increases in serum magnesium. Numerous cardiac and non-cardiac drugs can impact the ECG by directly affecting the electrical properties of pacemakers, specialized conduction systems, and atrial or ventricular cells. Drugs altering autonomic nervous system activity, vagal and sympathetic, may also influence pacemaker activity and conduction properties. Cardiologists often employ a shorthand classification system for drugs primarily used to treat arrhythmias. Despite its flaws, students and clinicians should be aware of this system. Class 1 drugs block sodium channels, potentially prolonging the QRS duration. They are subdivided into groups A, B, and C. Class 1A drugs also prolong repolarization via potassium channel blocking effects, increasing the risk of torsades de pointes and sudden cardiac arrest. Class 1B drugs include lidocaine and mexiletine, while classic drugs, like flecainide and propafenone, are used to treat atrial fibrillation and other supraventricular tachycardias. Antiarrhythmic Class 1 drugs and other pharmaceutical agents may paradoxically induce or promote life-threatening ventricular arrhythmias by altering myocardial cell electrical properties. These parrhythmic drug effects are of major clinical importance and discussed further in classes 16 and 19. Prolongation of the QT interval, with a life-threatening risk of torsades de pointes, can also occur with Class 3 drugs, such as Electrolyte, Defeatilide, Sotalol, Amiodarone and Dronidarone. Beta blockers Class 2, and specific calcium channel blockers, Class 4, primarily depress the sinus node and atrioventricular node, potentially causing bradycardias. The classification scheme's weaknesses include its inability to account for drugs with mixed effects, and its exclusion of important drugs like adenosine and digoxin, which fall under the Class 5 or Other category. The therapeutic and toxic effects of digitalis-related drugs, such as digoxin, will be discussed separately in Class 18. Psychotropic drugs can substantially alter the ECG and, in toxic doses, induce syncope or cardiac arrest due to ventricular tachyarrhythmia or asystole. They may also prolong the QRS interval, causing a bundle branch block-like pattern, or lengthen repolarization, predisposing patients to develop torsades de pointes. Various psychiatric drugs can prolong the QT interval, predisposing patients to torsades de pointes type ventricular tachycardia. These drugs include methadone and atypical or second-generation antipsychotics, such as risperidone and quetiapine. This topic will be discussed further in Class 16. Lithium carbonate, used to treat bipolar disorder, may cause sinus node pacemaker dysfunction or sinus exit block and severe bradycardia. Donepezil, used in Alzheimer's disease management, may induce or worsen bradyarrhythmias due to its anticholinesterase effects that enhance acetylcholine's action on the sinus and AV nodes. Systemic hypothermia may cause a unique ECG pattern, characterized by a hump-like elevation at the junction of the end of the QRS complex and the beginning of the ST segment, J-point, sometimes referred to as Osborn waves. This pattern disappears upon rewarming. The mechanism behind these prominent J waves is likely related to the differential effects of systemic cooling on ventricular repolarization. Prolongation of PR interval and QRS complex can also be observed. Most endocrine disorders do not produce specific ECG changes. However, the ECG may play a crucial role in diagnosing and managing hormonal abnormalities. For instance, hyperthyroidism, usually due to Graves' disease, is often linked to an inappropriately high resting sinus heart rate. An unexplained high sinus rate at rest or atrial fibrillation should raise suspicion for hyperthyroidism. In contrast, hypothyroidism is typically associated with a slow resting heart rate, sinus bradycardia. Severe hypothyroidism, myxedema, may lead to pericardial effusion and low voltage QRS complexes. Low QRS voltage is not specific and can be related to various mechanisms and causes. Metabolic acidosis and alkalosis by themselves are not associated with specific ECG findings. Metabolic acidosis is usually linked to hyperkalemia, while metabolic alkalosis is linked to hypokalemia. The ECG appearance will be dominated by these electrolyte disturbances, which, when severe, may lead or contribute to cardiac arrest. We appreciate your time spent learning with us today. If you found this course beneficial, we kindly ask for your support. Share this video with colleagues, subscribe to our channel, and leave us a positive rating. Furthermore, if possible, consider donating any amount via the link in the video description below. Your support empowers us to keep offering free, top-notch education to all who seek it. Before concluding, we're excited to announce our upcoming class on pericardial, myocardial, and pulmonary syndromes. This vital topic is essential for mastering ECG interpretation, and we can't wait to explore it further with you. To stay informed on our newest lessons, subscribe to our channel and click the notification bell. Thank you for being a part of our educational journey today, and we look forward to welcoming you to our next 100% online and complimentary ECG course.